Very good. So, good morning, ladies and gentlemen. So, I'll start with thanking the organizers for giving me the opportunity to address you today. And I think I've been given a very broad stage talking to you about the role of artificial intelligence and deep learning in multimodality medical imaging, and this is sufficiently broad mandates. I probably could have talked for the whole morning session today. So this is going to be one of these talks where we sort of have sections or probably go a little into much detail. Other sections we sort of skip over. Just have to allow some time for questions if anything is particularly missing from anybody's expectations. As a preamble, I would like actually to start by setting the scene and say that AI is not a set of fancy technical developments limited to academia. It will definitely have an important, significant impact on our professions. I'm a medical physicist myself, and probably it's going to be the same on nuclear medicine physicians and radiologists, and probably other disciplines as well. So there are serious initiatives at the European and international level supporting the addition of AI component to existing medical physics curriculum and graduate programs. And the AI work group of the European Federation of Organizations for Medical Physics published recently in Physica Medica, so probably consists of a set of guideline curriculum related to AI for the education and training of European medical physicists. And there are also similar debates taking place around the globe, as illustrated in this interesting point counterpoint article published in April issue of Medical Physics, which is the official journal of the American Association of Medical Physicists in the United States. So this is not really an outline, but kind of list of topics I'm going to cover in this talk. We'll start with a couple of slides, or probably three slides, to highlight advances in hybrid medical imaging technologies that we use in our research, and then share with you our experience in the development of AI-based solutions to address specific problems on these imaging modalities. Some of these developments go beyond um, the scope of this conference. So basically focus on low dose CT, PET, SPECT imaging, medical image segmentation. So address only CT components, although we have worked also in PET as well. Cross modality image conversion is very hot topic, quantitative imaging as well. And then I'll finish this presentation by a few slides covering AI-based internal radiation dosimetry calculations, and obviously, so what you see basically here in purple is not going to be covered here just for the sake of time. Just to start with, so this is the principle of a combined or hybrid PET-CT for those of you who never get exposed to this imaging modality. So basically, we'll start with what we call a scout scan. So scanning basically the patient with a planar image, and you've got the X-ray detectors here in the back, and in the bottom part of the scanner, and the X-ray tube on the top here. So we start with the scout scan. And then we define the axial field of view, and then we start the spiral CT. And then once the spiral CT is finished, so push the patient towards the PET detectors located in the second part of or in the rear of the PET-CT scanner, and then we acquire basically the PET scan, and then we fuse the two imaging modalities together to get the PET-CT scan that we present to our MDs or radiologists for reporting. And basically, so this report is going to be the outcome of this examination. Apologies here. So PET-MR is the second part of the story. So we've got different design trends actually commercialized. So the first one was commercialized by Philips, and this is the system that we have installed in our facility about 11 years ago. And so it's PET-CT, so kind of combined system with the sequential acquisition of the two scans. So we start with an MRI scan on 3 Tesla Chiva MRI scanner, and then you rotate the gantry to push the patient towards the PET detectors, and then acquire the PET scan, and then you basically fuse the two imaging modalities together to get the PET-MR scan. So different design trends have emerged, including the design by Siemens called the MMR. So this is an APD-based or solid-state detector, which is MR compatible, so allowing simultaneous instead of sequential acquisition. We've got also the Signal PET-MR system that you see in the bottom here, and then more recently, there is another design, so by a Chinese company called United Imaging. So these systems actually are designed based on silicon PMs, another solid-state technology, which is also MR compatible. And obviously those technologies enable to generate very high resolution images. So these are representative images generated by hybrid PSMRI scanners showing the typical quality soft tissue contrast that we get from the MR for brain scans, and so the high definition of myocardium on gated PET MRI scan. So let's start actually talking about the applications of AI in medical imaging with this article here published recently in European Radiology, where we basically developed a strategy for ultra-low dose CT scans. So we basically aimed to design an ultra-low dose CT examination protocol for COVID-19 patients using a deep learning approach, so suitable for significant radiation dose reduction for COVID-19 patients. So according to the physics of CT transmission data, we basically simulated ultra-low dose CT projection data from full dose projections in the synogram domain, so just to avoid scanning the patients twice. And this was carried out by adding statistically independent Poisson noise distribution and a Gaussian noise distribution corresponding to the characteristics that we see in this table. So basically reduction of the pitch factor, the tube current, and the KVP, so to end up with the low dose CT scan. So we use the residual neural network to generate the full dose CD from the low dose CT images, and then without any delay. So I'll show you some of the results from this study. So the quality of predicted CT images was assessed using quantitative and qualitative metrics. So scores assigned by radiologists ranging from 1 to 5. So one is the obviously the best, no, one is the lowest score and how 5 is the highest. So these were assigned reflecting so subjective assessments of image quality and also related COVID-19 features. So what you see on the left panel is the representative full dose image and corresponding ultra low dose, and the predicted full dose images on the right side. And obviously the predictions improved substantially the image quality, as you can see here. I don't want to play too much, but I think this is apparent from the scan here, so which enables basically most of the covered lesions to be easily classified by the radiologist. And another example where you see basically on the right side here shows an example of an outlier which you basically encounter in AI-based developments where the image quality was substantially improved. However, some of the relevant anatomical details were missing, and hence the network failed to recover the full detail of the images since the glass opacity, so one of the COVID lesions, was converted to another class, which is called consolidation. So we basically lose it, so the diagnostic quality of the scan. On the second phase, we did qualitative assessment, as I mentioned, so by the experienced radiologist, and this is the outcome comparing basically on the left side, you see the image quality metrics. So where the full predicted full dose images are mostly scored good or excellent, so 4 to 5. And overall scoring shows that the full dose images received the highest score, so 472 as an average, whereas the ultra low dose images were rated basically with the lowest score, so on average it was around 2.8. So on the right side here, you see the frequency for occurrence of each lesion type and the different series of images. So as you can see, so the GGO, so one of the types of COVID-19 lesions, had the highest occurrence in all images, were mixed, basically all had the same occurrence for all images, and changes in the essence of features are basically as can be seen here in the ultra low dose group. So GGO was shifted to normal features, whereas consolidation was turned to GGO. So the second work here, presented by one of my PhD students recently at the European Congress of Radiology, and it won the best research presentation. So the idea here is to develop an automated tool for segmentation of COVID-19 lesions. Obviously, so this can be performed on a routine basis by radiologists, but this is time-consuming, labor-intensive, and the procedure suffers from intra-observer variability. So the idea is to automate the process and to reduce the variability. All right, so this is basically the principle of the technique. So we have as an input is the chest CT scan of the patients, and then you've got convolutional neural network targeting basically the segmentation of the lung of the patients and the COVID-19 lesions separately, so in two-step process. So the pretty large database was included in this case, multicentric data sets coming from with patients being scanned in the United States, China, Russia, Italy, and Iran, and with different pathogens from mild to severe COVID-19 cases. And this is basically the outcome, as you can see. So let me take you through some of the results here. So this is one of the studies here. You probably see on the left side here, the radiologist segmentation compared to the AI predictions on the right side. So this is for the two starters, and I think you can see clearly a very good match between the segmentations performed by the radiologist and the one performed by the convolutional neural network. And you probably see it better here on the 3D illustrations. So for comparing again, so the segmentation by the radiologist and the AI-based solutions, so very good or excellent. So agreement between the two scans. Another application here I'm going to describe is the development of anthropomorphic computational models. So we have some experience in this area. So basically developed the number of computation models for pregnant patients, including the fetus, thoracoabdominal CT scans that we basically segment to generate computational models that can be used as input for multicolor based radiation dosimetry calculations. And we even developed a recently non-human primate model suitable also for radiation dosimetry studies. So this process actually is very time consuming because it takes weeks, sometimes months to segment manually the organs. So we decided actually to implement a convolutional neural network to automate the process, and then we apply this to a series of pregnant patients scanned in our emergency radiology department. So this is basically the outcome without going through the details of the convolutional neural network. So we see the original scene images, the manual segmentation performed by the radiologist, and the automated segmentation, basically the outcome of the AI-based solution. And again, I think you see a very good agreements. Probably see it better here on the 3D illustrations for two cases. You see the features here, which is depicted in this color here. So very good agreement for the two cases, even for other organs or parts from the features, which was specifically targeted here because the idea was to estimate the radiation dose to the features from abdominal X-ray CT examinations. So the outcome actually was, as I mentioned, so the radiation dose calculated to the features. And this results here basically summarize the comparison between the models actually resulting from the manual segmentation performed by the radiologist versus the AI-based algorithm. And you see that there is a very good agreement actually between organ doses to the lungs, to the uterus. Some exception probably for the lungs where we got slightly larger standard deviations actually because of mainly of registration issues, and also the uncertainties for this organ was a bit larger. So another application actually is in low dose PET imaging, as you can see from this article here published recently in the Journal of Nuclear Medicine. And the idea here is basically um, to use actually the high dose or the full dose scan, so denoted here as full dose FD, and to use the least mode file actually to generate through destination the low dose scan, and then train a network with the low dose and high dose and full dose scans to be able to predict the full dose images, so both in image space and in the projection space. So implementing this in projection space was not easy, as you can guess, because it's a time of flight scanner, so multidimensional data set generated by the top time flight scanner, and this obviously puts a constraint on this study in the sense that we did not include the time of flight information for the implementation. So without any delay, again, I just show you here, so the results for one of the clinical studies. As you can see, this is the full dose scan here on the top. So corresponding to an injection of 200 megabecquerel to the patients. So basically 30 minutes wait time and 20 minutes acquisition time. Very good image quality, and this is the equivalent of the low dose reconstruction, so corresponding to only 5% of the events, with the equivalent of 10 megabecquerel of injection of FDG, or the equivalent of 1 minute of acquisition time. So you see the image quality deteriorated substantially. And then these are the full dose predictions in the image space and in the projection or in the synogram space. And overall, the conclusion, as you see from the results later on, is that the deep learning-based prediction in the projection space outperform the prediction in the image space, in the sense that we managed to get rid of some of the artifacts that were observed in the deep learning based implementation in the image space. And you see this also nicely here in the bias maps, actually voxel-wise bias maps, where the bias were substantially higher actually for the deep learning prediction in the image space compared to the prediction in the synogram space. So again, we asked a number of nuclear medicine physicians to do the assessment of image quality, and you see that the full dose scans have got an average of 4.47. So yeah, between good and excellent, and then the low dose scan gets the lowest score, so average 1.4. And obviously, as I mentioned, so the predictions in the synogram space got a higher score, close actually to the full dose scans. So the next step is obviously the quantitative analysis. So we did a number of void-based analysis using the Hammersmith atlas. So basically a line that corresponds with all the images of the different patients to this atlas, and then we performed so void-based analysis for 83 brain regions. And what you see here is basically the blend Altman plots, where each data point reflects one brain region. So this confirms the results obtained from the joint histogram analysis, where the lowest SUV bias and smallest SUV variance were observed for the predictions in the synograms space. And although the SUV bias was extremely low for the low dose images, there's an increase in the variance compared to with the full dose predictions, as basically reported also by our nuclear medicine physicians. So the other studies basically to achieve quantitative imaging, again, so kind of extension of the previous work to use deep learning for ultra low dose whole body imaging, so extension from brain imaging to whole body imaging. And so this is what we did basically in this study here. So we walk you directly through the results. What you see here is one of our patients. We see a representative F18 FDG whole body PET image of a 66-year-old female patient, where you see the low dose CT image used basically for attenuation correction and anatomical mapping. And then you see the reference full dose images next to it, and the corresponding low dose images, and the predicted full dose images using basically so two different architectures, so residual networks and the cycle generated adversarial networks. So these are two different architectures used widely in medical image analysis, and obviously the low dose scan corresponds basically to 1/7 or 1/8 of the equivalent full dose scan. So the cycle can actually achieve a very good image quality and outperform basically the residual network evaluated in this work as well. So this is these are basically the top panel. You see the image quality assessments by nuclear medicine physicians for the low dose, full dose, and the two neural network architectures used in this work. So basically residual network and the cycle GAN. So the mean scores are presented on the top of the bar, and obviously, so you understand the principle of qualitative assessments. So 1 goes to an interpretable image quality, and 5 is excellent image quality. So on the bottom part here, you see the percentage of failed and accepted images. Where failed was assigned whenever, so lesion detectability was not good compared to the image displaying best image quality, and the two defined anatomical regions are shown on the right side. So basically we split it, so the whole body image into two zones, so one covering the brain and the head and neck, and the second one basically so covering the thorax and the abdomen and the pelvis as well. So with regard to lesion detectability, so we asked actually our nuclear medicine physicians to report on lesion detectability. So both ZGAN and residual network performed well, so depicting 19 out of and 17, so out of 19 lesions respectively. For lesions with high uptake, so basically SUV larger than 5.5. However, CGAN performed much better compared to the residual network, so depicting 27 and 23 out of 28 lesions for lesions with a reduced SUV or low tracer uptake and smaller size. So these are representative examples of lesion detectability shown in clinical study with the multifocal multicentric breast cancer with the skin involvement of the right breast and extensive lymph node metastasis, including the mediastinal nodes, comparing full dose and low dose images, as well as the synthesized images using both networks. So the lesion in the inferior external quadrant, so the long red arrow that you see here, was detected on the full dose, low dose, and the cycle GAN, but missed on the residual network. The mediastinal lymph node short red arrow indicated here was visible on the full dose and cycle GAN, but missed on both the low dose and the residual network. So significant achievement actually of this work. So another work that was performed by our group is basically to develop adversarial semantic structural learning strategy containing two generative adversarial cores for city synthesis. So basically what you see in the upper panel, and semantic structure extraction, so what you see in the lower panel. So the city synthesis core is governed by an L2 norm loss function for accurate city value estimation, while the semantic structure core exploits cross-entropy loss functions to maximize the fidelity of the generated synthetic city for the target MR image. And the city synthesis and semantic structure cores are composed of 22 and 16 layers respectively, and in total network contains about 54 million trainable parameters. So without any additional delay, so we'll show you the outcome. So this is basically what you see here, the MRI and the linearity of the same patients, and the deep learning strategy does a good job in depicting specifically the bony structures and the nasal cavities, whereas the commercial implementations on the Philips scanner is very crude approximation. So basically segmented MRI into a single tissue class, which is soft tissue inside the external contours, and you see also on the bias maps substantial loss of quantitative accuracy, as you can see here. So these are again some results for another patient here. We see the MRI, reference CG, and we compared actually the deep learning network to an atlas-based segmentation procedure developed again by our group, and we looked at two different quantitative metrics regarding the city value estimation. So both deep learning and atlas-based method performed similarly for the entire head region, resulting in mean absolute error of 101 and 103 house wind units respectively. However, these methods outperformed actually the segmentation based almost in all of the reported metrics. And as I mentioned it earlier, so deep learning techniques might result in gross errors due to the vulnerability of the quality of the input data, especially if you have some anatomical variability and also in the presence of high noise content. So in this study, so there was a single case of an outlier that was observed for deep learning-based strategies, so similar to other techniques basically reported in the literature. So this is another work that I don't have the time to cover, just to show you that what I mentioned that can be done in the image space can be done also in the sinogram space, especially if you have time-of-flight-based scanners, so you can actually devise similar procedures in the sinogram space, of taking advantage of the high temporal resolution of equivalent time-of-flight PET scanners. So the other work that I'm going to describe here very quickly is joint attenuation and scatter correction in the image space directly. And this basically the idea here is for implementation. So we use three different techniques. So 2D slice by slice implementation versus 3D using patches, and then fully 3D on the 32 slices. And the reason for choosing this number of slices is basically the memory limitations of the graphical processing units that was used actually to do this work. So this is directly the outcome of this study. So shows you actually head-to-head comparison of the representative clinical example of PET's image non-corrected for attenuation. So close to the CT scan that you see on the left side, and the PET scan corrected for attenuation using CT-based attenuation correction procedure implemented on the commercial scanner. So this is the de facto standard technique actually used in commercial systems. And these are the predictions actually by the different approaches implemented in this work. So basically 2D slice by slice, 3D using patches, and then 3D slices consisting basically of 32 slices. And you see the base maps here on the right side. So what was important actually to notice in this study is that one of the issues actually that we face in clinical setting when you use CT-based attenuation correction is the misregistration issue in the thorax and the upper abdomen that takes place in 20 or 30% of the cases. And so the MDs are obliged to look to the non-corrected images actually to solve those issues. And basically, so what's happened here is that we noticed that in some cases, so the deep learning strategy managed to solve this problem in the sense that it compensated for this motion issues, so basically taking place because of differences in breathing patterns between the PETs and the CT scans. So the last example I have here is internal dosimetry. I hope that I did not exceed my time. And so the idea here is that we know that in current practice, so dose monitoring is commonly performed using simply modified models, such as those devised by the Medical Internal Radiation Dose Committee. And the voxel level mirror schema is defined basically as a 3D voxel-wise matrix, so implementing the mean absorbed dose to target voxel per unit activity in a source voxel embedded in infinite homogeneous medium. And the idea of our work is basically to extend the voxel scale mirrored approach from a single S-value kernel to specific S-value kernels corresponding to patient-specific anatomy to construct 3D dose maps using hybrid emission transmission image sets. And in this context, we'll basically employ deep convolutional network to predict the distribution of deposited energy representing specific S values from a single source in the center of 3D kernel composed of human-based body geometry. And the training sets consists basically of density maps extracted from city images and the reference box-wise S values were generated using Monte Carlo simulation. So to assess the impact of medium heterogeneity on dosimetry results, so we generated the whole body dose map of the positive energy that was basically compared actually to the Monte Carlo calculations. And I'm going just to skip a couple of slides here, just for the sake of time, and skip again the summary and thank my team for their excellent work. And I thank you also for your attention. Happy to answer questions. And again, thank you very much for your attention. Thank you so much.